Good afternoon, everyone. I'll be presenting on the sarcoidosis, tuberculosis conundrum, and the role of serum ACE, MAN2, and lymphocyte count. Ocular TB and sarcoidosis are two diseases with overlapping clinical features, and differentiating one from the other is a challenging task. They are even postulated as opposing presentations of the same disease spectrum. ACE, MAN2, and lymphocyte are very commonly used in practice, but there is a lot of overlap in results in sarcoid and TB, and sensitivity and specificity of these tests vary in different study populations. Studies depicting their utility in combination are scarce and are very relevant in TB endemic countries like India. Our study attempts to address this lacunae in the literature. The purpose was to evaluate the diagnostic utility of serum ACE, MAN2 test, and lymphocyte count, both in isolation and combination in the diagnosis of ocular TB and sarcoidosis. The outcomes were sensitivity, specificity, positive and negative predictive value. This was a prospective observational study done for 2 years in Aravind Hospital, Pondicherry, in 95 patients with acute uveitis of age more than 18 years. We excluded patients with history of trauma, immunosuppression, use of ACE inhibitors, and steroids and immunosuppressants. We used a revised IWS criteria for sarcoidosis, and we used the Gupta et al. Criteria for diagnosing ocular TB. ACE was estimated using a substrate FAPPG. We analyzed 118 eyes of 95 patients. Ocular TB was seen in 12% of the study population, and sarcoidosis was seen in 20% of the study population. ACE was elevated in 89% of the sarcoid group and only in 33% of the TB group. The mean value was 76.2, which was statistically significant compared to that of TB. MAN2 was positive in 58% of the TB group and only in 15% of the sarcoid group. This was also statistically significant. Lymphopenia was seen only in the sarcoid group, and this was seen in 10%. None of the other groups had samples having lymphopenia. Elevated ACE had a very good sensitivity and negative predictive value in detecting ocular sarcoidosis. Also, negative MAN2 had a very good sensitivity and negative predictive value, but their specificity and PPV was less. Also, as lymphopenia was seen only in the sarcoid group, the specificity and PPV became as high as 100%. Also, when we combined the three parameters, the specificity and PPV was as high as 100%. In ocular TB, we analyzed the role of both elevated and non-elevated ACE, and they both had a high NPV, and there was an overlap. Positive MAN2 had a very good negative predictive value in detecting TB. The area under ROC curve was maximum for elevated ACE when compared to that of lymphopenia and MAN2, and this was statistically significant. In ocular TB, the positive MAN2 had a very high AUROC of 0.835, which was also statistically significant. The strengths are, this is a prospective study where screening is done by a single trained observer, and to the best of our knowledge, no study conducted so far has tested the combined utility of elevated ACE, negative MAN2, and lymphopenia in the diagnosis of ocular sarcoidosis. Our study also analyzed the utility of serum ACE in ocular TB. This is an observational study where consecutive patients were enrolled, so there was no randomization. Also, study period included the peak phases of COVID pandemic, so viremia due to coexisting or previous infections could have affected the lymphocyte values. There were no biopsy-proven cases. Subjects included were either presumed or probable sarcoidosis and probable and possible ocular TB. What this study adds to. There was a study by Elango and Bishwas et al. From South India which said ACE was an independent risk factor rather than lymphopenia or when used in combination. A study by Philippine Court et al. Says combination of ACE and lymphopenia demonstrated a better diagnostic performance than these tests used alone. According to our study, combination of these three parameters, that is elevated ACE, a negative MAN2, and lymphopenia, had a better ability to diagnose ocular sarcoidosis owing to high specificity and PPV than these tests in isolation. Also, as the NPV is very high, in subjects with normal ACE, further screening for sarcoidosis may be required only if clinical suspicion is high. Even though ACE was elevated in some patients with ocular TB, it may not serve as a useful screening or diagnostic tool in detection of TB. Also, as NPV is very high in case of negative MAN2, further screening for TB may be necessary only if there is a strong clinical suspicion. Serum ACE level assay is a better test for discriminating ocular sarcoid when compared to negative MAN2 and lymphopenia in discriminating sarcoid from other diagnoses. Also, MAN2 is a better test for discriminating ocular TB from other diagnoses. These are my references. Thank you for listening again.
Again, nice presentation. Just one last question, that when you are interpreting the results of MAN2 test, what history should you take from the patient regarding previous testing. Before you comment on the outcomes of negative MAN2 or a positive MAN2 test,
Yes, sir.
is there some history regarding previous testing that you should take from the patient?
Yes, sir. In our population, there is a high false negative for so the BCG vaccination history and immunosuppression can affect
See, what happens that most of the time, I believe you are working in a tertiary care center.
Yes.
So a patient must have undergone a MAN2 test in past 2 to 3 years.
Yes, sir.
So once
can
the patient has been tested,
Yes.
and you retest the patient in next 18 to 24 months,
Yes, sir. They can
you
be
will get a falsely
positive.
high MAN2
Yes, sir. Yes, sir.
reactivity.
Yes, sir.
So that part should be brought out in
Yes,
the
sir.
outcome.